after her talk. So the first speaker of the morning is Francesca Rubulotta. New metrics results from the third consensus conference on rapid response systems. Francesca is a consultant and senior clinical lecturer in anaesthesia and intensive care medicine at the Imperial College Medical School in London, and has a number of other significantly impressive bios, which I won't read all through at the moment. Welcome, thank you. I think you just press your slides forward on that.
Good morning. Can you hear me? Thank you so much. I'm very impressed by your ability to pronounce my English not friendly name. As you can imagine, I'm not British, and I'm struggling with Brexit as much as Australian can understand. Even being in England, I don't understand a thing of what's going on. I would like to thank Daryl for being here, and I'm so excited to be in Australia. You know, Melbourne is the city of Ken Illman, where everything started. So for me, it's like living the dream of talking to you here. I don't know what I'm doing actually, but let's go through what the work of lots of experts have done in England last year in 2018, and the reason why we wanted to go through the trouble of identifying metrics for the rapid response system. So these are new metrics that we wanted to look at because we realized that actually it's very difficult to understand whether your rapid response system is working appropriately or not. Trouble happen anytime. It's really difficult to plan when things can occur. Therefore, we need to really be ready and staffed and prepared day and night. And the quality of things we know that changes actually during the day. And therefore, metrics needed to be selected in order to understand whether the quality of your rapid response is optimal or not. We were very confused also on what to look at, and we realized that actually there's nothing really out there that can tell us whether the quality of rapid response is good, whether we provided a good experience to the patients, whether we provided a good experience to the staff, whether we are globally effective, and actually what about cost of it. The framework we adopted at the time of the consensus was the quadruple aim. That is something that is recently being introduced. So for a long time, the Institute of Health Improvements used the triple aim, looking at patients' experience, population, and cost reduction. But the quadruple aim is finally looking also at the staff and the impact of second victims, which is a really big problem. What recommendation we use? We have 10 recommendations, and we gave them different importance. So there are some that you will see are essential. So we expect every rapid response system outreach to have those elements. Some are recommended, some optional. And obviously, when we talk about costs, we go to experimental. For an Italian woman, it's very difficult to contain the cost, so everything is experimental. Obviously, I was leading this group. So the working group were 3 clinical metrics, patient, family, and staff, and then financial metrics. We were really careful to include as many people as possible in terms of age groups, origin, background, knowledge, experience. So we had almost all the continents. We had doctors, we had nurses, we had patients representative. We even had experts in economics. The clinical metrics, so bedside issues, is the biggest group. You can see it's a long list of people linked to that. You can see Daryl was there, John Welsh, the president of the previous president, past president of the society, Michael De Vita. So some of the key leading people were in workstream 1. And talking about the clinical metrics, we really like to divide the concept in 2 main parts. So I don't know whether, yes, so we wanted to split what the process was from the outcomes, because we know a lot about outcome. We know a lot about reducing cardiac arrest, admission to ICU, death, but we never really look at the process, which actually is probably the most important thing. And we really wanted to include some metrics that tell us how the process is and is improving and is compared to other institutions, and what the outcome is. And you can see in brackets here that 3 of the 5 clinical metrics actually are related to the process. And obviously the process relates to deterioration, activation, intervention, and only a small part really is the outcome. So we should measure outcome, but it's not the whole thing that matters. And it's also important to say that the process can change much more rapidly than the outcome. It might take years for your hospital to measure a reduction in cardiac arrest. It might take a shorter period of time to actually respond quicker, better to the call in the ward. So looking at the population that is related to those 5 clinical metrics, you can see that the first one looks at patients in the ward, the second, the 5th and the 3rd, sorry, I cannot point without losing my voice, related to patients in the ICU, but there are others that are in the transition between, the ward and the ICU, and the 2 things a little bit overlap. So let's go quickly. I think it's very challenging in 15 minutes to go into the detail of 10 metrics, and that's probably why you want to ask, I hope you will want to ask me a question at the end, but I try to go through showing the criticality, showing the problematic issue, and then maybe we can make some comments at the end. So the first one is ward cardiac arrest. Very important points is always try to find the numerator and the denominator, because metrics are related to a value, a number. So for any of each of those, we tried always to identify a population to apply the numerator on. So the first metric is non-ICU, no procedural in-hospital cardiac arrest, and we spent long time to agree on the denominator, which is 10,000 adult ward days. Previously, lots of paper talked about 1,000 admission, 1,000 critical admission, but the agreement of experts now is 10,000 adult ward days. The other critical point of this first metric is whether or not to include patients with do not attempt to resuscitate. Why is that challenging? It's very obvious probably in countries like Australia, but if you want to use international metrics, there's countries like Italy, Middle East, South America, where it's not so obvious which patients are with a do not attempt to resuscitation. They cannot be documented on the chart, and the practice is very controversial. So we need to look at those countries if we want to really benchmark the systems across the globe. This first metric is essential. We want every system to look at this. Definition of cardiac arrest was also a challenging point, and the definition that is used in this paper is chest compression and defibrillation in the setting of not perfusing cardiac rhythm, or found dead in bed without a do not resuscitation code. This is also challenging. Please ask me a question at the end. Potential preventable cardiac arrest. So the numerator is ward arrest in patients meeting locally defined criteria. Why locally defined criteria? If you go to England, they will say the news, end of story. We want a truly international consensus. So whatever you use, even a single criteria, whatever it is, the way that you call for help, is it verbal, is it written, as soon as the clock starts, we want to have a response if your system has some efficiency. So regardless the criteria, we want to look at, as a numerator, the word cardiac arrest that are at least 30 minutes after and within 24 hours from the time the patient has met those criteria. The denominator is the total word cardiac arrest. This, again, is one of the essential metrics. Number 3 is more related to the process, as you said at the beginning, is the timely first responder review in patients meeting deterioration criteria, and we were looking to senior review, not just a junior review. So we want to know how long it takes for this first review. This recommendation, unfortunately, is recommended because we realize that cannot be internationally met, but as a group of experts, we really highly recommend this to be achieved. Timelines of critical care application. This is not just looking at the patient, it's doing something about the deterioration. And we want to see how many of those patients actually have an intervention within the first 6 hours. So the numerator is patients receiving critical care application within 6 hours, and the denominator is those deteriorating in the 24 hours. The fifth goal of care treatment documentation. So this is an optional recommendation, but it's very crucial. We are truly bad in documenting our action. A good system needs to be able to report what has happened, otherwise it's impossible to improve. So we cannot make it as essential, but definitely will be very good to do. Second group is metrics related to patient, family, and staff experience. This group is smaller, but the content is crucial because we really underestimate the importance of the patients as a monitoring system and the family, of course, of critically ill patients. Metric number 6 is a system in place where a patient and a family can activate the rapid response. The inclusion criteria are the whole hospital, all the words. This is essential. And this is very challenging. We are really curious to know what this will cause when every rapid response system in the world is asked to have a family involved. And I would not want to be in Italy when this is going to start. But this is probably, well, you know, I think there is let's talk about this, because there's no evidence that any family has overcalled the system. And most of the time, it's an issue of communication. This might trigger some data. If it's really impossible, then we can change it. There's no point to change it if we have no proof, apart our personal subjective concern that it might be difficult. Metric number 6 is the proportion of patients that activate the rapid response. The denominator is the total number of calls, and this is optional. Would be nice to have. The metric number 8 is, does the organization evaluate its safety culture? This is really important because as more as we work with rapid response, we realize that this is a quality improvement project. It's not just a team, is not just an idea, but is something to do with a global safety culture. And we have evidence from previous meta-analysis that actually the data and the type of studies that are done in this field are always low quality. This is being published in 2013 in the Annal of Internal Medicine, and you can see that there were only 2 studies that were talking about the patient safety climate, and the results were actually very poor. Last group, financial group, you can see is the most diverse group because we got, as I said, economic PhD as part of that. Define the last 2 metrics that are considered experimental. Unfortunately, the only 2 metrics that we could find are related to the intensive care unit length of stay and the intensive care unit, and the overall hospital length of stay. Why is that? Just because these are easy to measure across the globe, and we have the assumption that if we intervene on time, we might reduce the time that the patient stays either in the hospital or the intensive care unit. Obviously, it's an assumption, and that is why these are still experimental. We thought about a huge number of other possibilities, but we have only the nominator of this. We cannot find really a possible denominator to make those effective. Just to give you an example, the cost of second victims. Lots of the money saved by the rapid response system are related to things that you cannot cost easily. Patient retention, staff retention, patient satisfaction, prevention of lawsuit. How can you objectively measure those and find a really reliable denominator of those? I think this is a quite quick run through the 10. I think finishing and talking about this might be more beneficial. We are a small group, so please come in with what your impressions are instead of me just talking to you, which is never useful. And just as a last slide, I would like to ask to forgive me because I need to leave a little bit earlier. We will talk about equality and diversity, and I would like to invite you to Sicily to this conference, which will talk about women in intensive care in June next year. Thank you so much.
Thank you very much, Francesca. You might want to just stay up here for a minute because we might just take some questions from you because I think you've got to disappear off for you're going next door, aren't you? So, if there are any questions for Francesca, could we do them now, please? Yes.
Thank you so much. So one of the first questions we ask when we start this consensus conference is, who is the deteriorating patient? Who is it? Anyone in the audience, can you tell me which patient is the deteriorating patient in your institution? Anyone? Well, you look like the consensus experts. Right, so after a long time we realized that there is not such a patient, and effectively the deteriorating patient changes from institution to institution based on the fact that the deteriorating patient is that patient that has not, that is changing his clinical physiology and has not enough resources at the bedside to match his needs. So it's a mismatch between the supply and the demand. The supply in that specific ward is not enough to match the demand. So what we define critical care service is the provision of specific critical care staff, medication, knowledge, expertise at the bedside when it's needed. Of course, if there is a senior nurse, a lot of monitoring resources at the bedside, the trigger for deterioration and for a review is higher than there is like low staff, not very many nurses, not very many monitoring systems at the bedside. So the threshold might change quite significantly across the globe. And the concept of deterioration is just a simple concept of supply and demand. When the supply is not enough, you need to have someone at the bedside at least to recognize this and ask for help.
Okay, thank you very much. Thank you. Thanks very much, Francesca.